Dr. Asher, I let you introduce our next speaker, Dr. Weiner.
Yes, my great pleasure is to welcome my friend Stephen Weiner, fascioplastic surgeon from Florida, United States. And he is one of the dominant teachers dedicated to this very important growing new segment, who is the echography or ultrasonography. So he will speak today about echography anatomy for optimized injections. And he will introduce his activities through sonoaesthetic. So thanks to sonoaesthetic, to support this webinar.
All right, so I'm Dr. Weiner, and thank you for having me today. And what I'm going to do is go through echography, or ultrasound as we call it in the United States. I'm going to go from head down and go for the critical areas of anatomy here. So what can you do with ultrasound? Basically, we're going to discuss the anatomy and vascular anatomy in real time on our patients. So we don't have to go and get MRI or CAT scan. We can do it right there without any radiation and see exactly the areas that we're interested in. You could also look at fillers. You can also look at where you're placing your product using ultrasound guidance. So let's start with the temples. And the temples is a very tricky area because of this superficial temporal artery, which is an area where blindness can occur. So you see the superficial temporal artery right here, and it's in the superficial temporal fascia. And over here, you see the intermediate temporal fat pad, and that's in between the superficial and the deep temporal fascia. It kind of splits. The superficial layer of the deep temporal fascia and the deep layer of the deep temporal fascia. And I like to place my filler in this zone right here between the superficial temporal fascia and the deep temporal fascia. Other people like to place it superficially, and some people like to place it deep. But I'm going to show you the deep injection isn't as safe as you think it is, because what you're going to see right here is that deep temporal artery is at risk when you do that gunshot technique or the one up, one over technique. So just be careful of that deep temporal artery when you're doing those deep injections onto the bone. So what I'm doing right here, this is very difficult to see, and I was able to find it with my Clarius ultrasound, that middle temporal vein. So the middle temporal vein lies within that intermediate temporal fat, and it's at risk for actually pulmonary embolus if you inject it. There have been cases of that and actually death associated with injections in this area. So just be careful of that vein right there. There's a feeder vein called the sentinel vein, which leads from the superficial veins into this middle temporal vein. So what I'm showing right here is the ultrasound, and I'm going to be moving it along just inferior to the infraorbital rim. And what you can see is the darker area here is the orbicularis oculi. And then as you go more laterally, you start to see the medial SUF, which is the deep fat pad just underneath the orbital rim. We'll go through it again. Here's the tear trough area. You see, there's not much to the tear trough. There's skin, there's muscle, and there's bone. And that tear trough ligament splits the orbicularis oculi muscle into an orbital and a palpebral segment. But here's the medial SUF. This is the area where you want to put your filler along the periosteum when you're injecting in the medial area of the orbit. So right here, I'm looking at the infraorbital artery and foramen. And you see a little break in the bone. That's what signifies a foramen with ultrasound. And you see the infraorbital artery. And if you measure it, it's about 1.2 centimeters deep. It's about 1 centimeter deep, 0.99 centimeters deep. And it's 1.2 millimeters in diameter here. And that is surrounded by the deep medial cheek fat. And you see the SMAS. The SMAS is a constant. It's usually about 5 millimeters in the midface. It's anywhere between 3 and 5 millimeters. So that's a good reference point for all your ultrasound. So what I'm doing right here is I'm looking right here. This is often not discussed much. This is the zygomaticofacial foramen. And there's an artery there, the zygomaticofacial artery too, that's at risk when you're injecting in a little bit too high in the cheek area here. And superficial to that is this lateral SUF. And then just superficial to that is the orbicularis oris, because the SUF is a suborbicularis oculi. I'm sorry, that's not the orbicularis oris, it's orbicularis oculi. So it's a suborbicularis oculi fat pad right here. So this is what Dr. Asher was discussing about the angular artery in the piriform. And you can see this artery is about midpoint between the skin and the periosteum. And so this is a great area to use your ultrasound to gauge how deep you want to do your injections and if it's safe to do the injections along the periosteum, or do you want to do them superficially? So you can place them both superficially and deep. I actually usually put it superficially, but a lot of people like to go down into the periosteum with their needle. So it's usually about 5 millimeters deep in the piriform area. So this is looking at the nasolabial fold, as Dr. Asher also discussed. And what you can see on the left is actually something called B mode, which is not using the color Doppler that we've been using to visualize vascular. But you can see the pulsations and you can see the artery even in B mode right here. So the blood is going to be dark because it's mostly liquid, and liquid or fluid or HA, it's going to be dark because it doesn't reflect any of the ultrasound. And over here is the color Doppler of the nasolabial fold angular artery. So this is the transverse facial artery, and this is in the submalar area. And I want to point out that this is a very superficial artery as you go more medially, and it's been the cause of multiple occlusions when you're very subcutaneous in this area. So just be careful. So the transverse facial artery comes off of the superficial temporal artery in the preauricular area, and it goes through the parotid gland, and then it goes along the parotid-masseteric fascia as it goes anteriorly. And then it pierces through the SMAS and hooks up with the infraorbital artery. So this is an important artery, causes a lot of headaches for some people. So a lot of people inject noses, but you have to be careful of this dorsal nasal artery. As you can see, this dorsal nasal artery doesn't leave you much room between the artery and the periosteum of the nose. So I highly suggest that you use your ultrasound to find out where this artery is. It's often paramedial. It's not actually in the midline, but in some cases it is. So you just have to be careful. In this case, the distance between the artery and the periosteum is 0.6 millimeters. So the bevel of a needle is often larger than that. So you could be injecting on the periosteum and still in that dorsal nasal artery. So just be careful there. So when injecting the chins, one of the main concerns should be that ascending branch of that submental artery. So the submental artery branches off of the facial artery below the mandibular border, and then it comes over the mandible, and sometimes there's a deep and a superficial component, and it's usually not midline, it's usually paramedial. In this case, we have the superficial component of the ascending branch of that submental artery. Obviously, there's other arteries in this area too, like the mental artery and the inferior labial artery, which all anastomose. So there have been cases of injection in occlusion of this artery actually causing lingual occlusion as well and necrosis, because it does communicate with the lingual artery as well. So be careful. As Dr. Asher likes to say, always move. And I like moving, even if you're using a cannula. Boluses are, and inject slowly. Boluses are more apt to cause occlusion than a moving cannula or needle. So right here, I'm just pointing out the superior labial artery, as Dr. Asher discussed. It's below the orbicularis oris muscle, which is right here. So the muscles are going to be kind of a dark gray. They're not quite black because there is some fibrous tissue, but there's a lot of blood, and that's why it's closer to black than it is white. So here's the superior labial artery sitting in its correct position below the orbicularis oris muscle. And what I'm pointing out here is he also mentioned this. This is the labial mental artery. And it's always in a position that's deep to the DAO muscle, the depressor angularis oris muscle. And I want to also point out that the deep lateral chin fat, that's a fat pad that you want to inject deeply when you're injecting the chin. So it's going to be a little more laterally. It's also where the pregal sulcus is. So this is an area of concern, but if you're below the artery, you're safe. This often branches to the inferior labial artery as well. So ultrasound echography is needed because anatomy is inherently variable. As Dr. Asher stated, there's a lot of variations to the facial artery. It's really real-time anatomy, very low cost, and there's no radiation. And injections are being done in increasing higher risk areas. So we need to know the anatomy better to have safer injections. It's better to prevent an occlusion than to actually treat one. But if you have an occlusion, ultrasound is becoming the gold standard to treat the complications much more efficiently than sort of randomly injecting hyaluronidase. So this is my company, Sonosthetics. We call it the next wave of aesthetics. It does ultrasound trainings and networking. And this is my contact information on my website. So currently I have trainings in the future in Boston, in New York, as well as Dallas. I've done some in my office in Florida as well. And I'm happy to help out with this presentation. So this is when I first learned about ultrasound in cutaneous, in Amsterdam. And here's Leonie Shekeld. She's probably the innovator of ultrasound for the face. And here's Oscar. And you recognize this guy. Thank you for having me today.
Stephen, very clear, very didactic. So it was absolutely something now we need to go to the consideration that taking now the basic of ultrasonography and anatomy, now it's fundamental. And I would like to have the point of view of Sergio and Emmanuel concerning this point, because we know that more and more we have problems of injections, and we know that more and more the problem is because the people ignore how to deal with the location of the vessels, and mainly, of course, the arteria. And I think that more and more we are going to have to document what we have done before the injections. And one of the documentation could be the fact that we are going to have this primary vision of the vessel through the ultrasonic system. So Sergio, what is your vision about that?
Once I've heard that every time you get with a needle inside the face, it's like going into a wood with your eyes closed. So, and you can find dangers in this area. If you are dealing with ultrasound, you can open your eyes in a way and know in advance what can happen, and know after, if you had a problem, what did happen. So no way it's in the way of the future of the techniques of injecting.
Yes, but what do you think about the fact that more and more, due to the legalcy, we are going to be obliged to document what we have done?
Absolutely. And the other thing in areas like Latin America, another advantage of the sonography is that you can identify what has been injected previously. Many times
exactly. That's the other important way. Stephen was not on this target, but of course we have to insist on that, right?
Yes, two things: the vascular issue, the position of the arteria that, as you have shown, not always follow the same theoretical pathway. So the variation seems to be the rule, and the only way to identify is to get a real view of what's happened. I have seen the Korean people injecting at the same time than doing the echography. I think probably in some years, all of us will be doing that.
Okay. So Emmanuel, what is your feeling?
Oh, my feeling, Benjamin, is that ultrasound is the future, I think, in our practice of aesthetics. Of course, all of us needs to know the most common danger zones in order to be aware of.
And Emmanuel, what is
Yes.
your positioning? Because you are a startup guy, a very successful startup guy, and I would like to congratulate you with what you have done since now the 3 past years.
Thank
But
you.
let's go to one interrogation between you and us, not me, but us. We know that now from many startups, we have the intelligent needle, which seems to be, of course, something will make sense. As you know, we have many beginning of successful startup who promote the fact that when you are inside the vessel, you are going to react because you know that you are inside the vessel. But I'm very surprised, sorry, because of course, all of them are my friends. And of course, I have a lot of respect for what they have done. But you have to be the time before, meaning you need to diagnose the vessel before enter inside the vessel. So what do you think about that?
I think the knowledge of anatomy is essential. You are not supposed to ignore the important areas where you are supposed to really be careful when you inject your patients. And this is what I try to do, to propose tools to put in everybody's hands the possibility to have those alerts, when you are close to this
yes,
area.
and one more time, before entering inside the vessel, that would be the best, right?
Yes, I totally agree, Benjamin.
Okay, so Emmanuel, stay with us, of course, and we are
Sure.
going to listen to you just in a while after Sergio.